Welcome to Podplast UK.
Hello and welcome to Podplast UK, the podcast where we unpack plastic surgery topics, one practical concept at a time. I'm Aasim, a plastic surgery registrar working in the West Midlands in the UK, and today, for this, one of our shorter cappuccino break podcasts, we shall be discussing a cornerstone of trauma management, the Gustilo-Anderson Classification for open fractures. So, go and grab a cappuccino, or your favourite bevy, and let's break it down. So what is the Gustilo-Anderson Classification? The Gustilo-Anderson Classification is the most widely used system for grading open fractures, specifically long bone injuries. It stratifies open fractures based on wound size, the energy level causing the injury, soft tissue damage, level of contamination, extent of periosteal stripping, and severity of bony injury. Whilst the Gustilo-Anderson Classification was developed to determine infection risk and prognosis, the classification is also used now to ensure the delivery of optimal management of open fractures by guiding one to decide the surgical skill mix required to manage an open fracture, a combination of orthopaedic, plastic and vascular surgery, dependent upon the severity of the injury, and the bony fixation and soft tissue reconstructive approaches appropriate for the injury. The Gustilo-Anderson Classification is a common, indeed at least in the UK, preferred communication tool for discussing or referring acute cases. And it is also, as many classifications are, useful for facilitating research and audit by facilitating the grouping and comparing of cases and expressing any insights gained in a common language. It is important to appreciate from the offset that classification occurs after wound excision and not in ED, because it is not uncommon to underestimate the extent of the injury, especially if there is a component of degloving of the soft tissue. Obviously, this does not apply in the case of a devascularized limb, and the type of injury, type 3C, is obvious immediately, even in ED. In the initial classification of open fractures, published in the American edition of Journal of Bone and Joint Surgery in 1976, titled Prevention of Infection in the Treatment of 1025 Open Fractures of Long Bones, Ramon Gustillo and John Anderson classified open fractures into three types, 1, 2 and 3. However, because of the varied severity and prognosis, the designation of type 3 open fractures was found to be too inclusive. So, in 1984, Gustillo, Mendoza and Williams published their follow-up paper in the Journal of Trauma, titled Problems in the Management of Type 3 Severe Open Fractures, a New Classification of Type 3 Open Fractures. In this landmark paper, Type 3 was further subclassified into 3A, 3B and 3C. So the classification of open fractures, as adopted by BAPRAS and the BOA in the guidelines on the management of open fractures, consists of type 1, 2, 3A, 3B and 3C. Now, let's walk through the categories. Type 1. The wound is less than 1 centimetre, it's clean, the fracture is simple, that is to say not segmental or comminuted, and there is no associated vascular injury requiring repair. Although not included in the initial description, these are low-energy wounds, which can be sutured closed. Whilst these injuries are generally low infection risk, the wounds, including the fracture ends, must still be treated with adequate wound excision, thorough decontamination, and of course the appropriate antibiotic cover. Type 2. The wound is between 1 to 10 centimetres, without extensive soft tissue damage, flaps or avulsions. It's clean or with minimal contamination. The fracture is simple, that is to say not segmental or comminuted, and there is no associated vascular injury requiring repair. These are low to moderate energy wounds, and management is identical to type 1. Type 3 was initially defined in the 1976 paper as open segmental fracture, or an open fracture with extensive soft tissue damage, or a traumatic amputation. Open fractures secondary to gunshot injuries, severely contaminated open fractures, such as farmyard and sewage injuries, and any open fracture associated with a vascular injury requiring repair were included in type 3. These were often high-energy wounds. However, as we discussed before, this category was subdivided into a further 3 categories. Let's unpack these. Type 3A. adequate soft tissue coverage of the fracture despite extensive lacerations or flaps or a high energy injury, irrespective of size of the wound and or contamination. Think open fracture of the leg with deep lacerations but adequate soft tissue left after appropriate wound excision to close primarily, not requiring reconstruction with skin grafts or flaps. Type 3B is defined as an open fracture with extensive soft tissue loss, periosteal stripping with exposed bare bone or fracture, often associated with significant contamination, requires soft tissue reconstruction, usually a flap. Type 3C, any open fracture with arterial injury requiring repair. This is a crucial point. Regardless of wound size or soft tissue loss, vascular compromise upgrades it to 3C. These are limb-threatening injuries that need immediate vascular assessment and intervention. What should be obvious is that type 1, 2 and 3A are not injuries that require soft tissue reconstruction, whilst type 3B by definition requires soft tissue reconstruction, usually a flap, and 3C may require input from vascular and or plastic surgery. So, to recap, type 1 is clean, less than 1 centimetre of wound, minimal soft tissue damage. Type 2, 1 to 10 centimetres, moderate soft tissue injury. Type 3A, extensive wound, adequate soft tissue coverage of the fracture, not requiring reconstruction with skin grafts or flaps. Type 3B, requires reconstruction with skin grafts or flaps, usually a flap. Type 3C, vascular injury needing repair. Always remember, classify after wound excision, except obviously for type 3C, act early, and involve orthoplastics for all long bone open fractures with a combined approach in a major trauma centre recommended for optimal results. The Gustilo-Anderson Classification is employed in the joint BAPRAS and BOA guidelines, the standards for the management of open fractures. This comprehensive document you must read for all plastics and orthopaedic trainees. You can listen to our podcast episode covering these guidelines on Podplast UK. I hope you found this useful. Thanks for tuning into Podplast UK.
Podplast UK is a collaboration between UK and Irish plastic surgery trainees and consultants. The content reflects individuals' practice and opinions may vary. If you have any feedback, do get in touch. We hope that this has been interesting and useful. If it has, remember to follow us for future sessions.